Good afternoon, and welcome to the 24th annual and second virtual Matas David and Hina Stahl Memorial Lecture in Bioethics, featuring our speaker, Dr. Ole Norheim. He is a professor and director of the Bergen Center for Ethics and Priority Setting at the University of Bergen in Norway. My name is Dr. Dalia Shefetz, and I am a professor of pediatrics here at Rutgers Robert Wood Johnson Medical School, and I am the co-chair of this lecture, along with my colleague, Dr. Nir Eyal. The Stahl Memorial Lecture series began in 1998 with a donation by Dr. Theodore Stahl and his wife, Dr. Eva Stahl, to the Robert Wood Johnson Medical School. Both lifelong physicians, the bioethics inherent in medicine was always a topic of great interest to them, and the funds were used to invite top bioethicists to our medical school. The lectureship was created in memory of Dr. Ted Stahl's parents, who lived through two major wars, the Depression and the Holocaust. Throughout their lifetime, they became renowned in their commitment to ethical values and the appreciation of history and culture. We are so grateful to Dr. Stahl and the Stahl family for the contribution of this lecture to our medical school. Ethical values are integral to the practice of medicine and the ways we train our medical students and other trainees. We are happy to give our community a chance to hear and interact with top bioethicists now from all over the world as we have a virtual event. We want this lecture to be engaging and participatory, so I encourage the audience to submit questions via the Q&A function, and Dr. Norheim will answer them after his presentation. I am happy now to introduce my co-chair, Dr. Nir Eyal. Dr. Eyal is the inaugural Henry Rutgers Professor of Bioethics and Director of the Rutgers Center for Population-Level Bioethics. One of our Stahl Lecture speaker alumni, Dr. Eyal is an expert in population-level bioethics as well as in clinical bioethics. His main research foci are health inequities, health promotion, and research ethics. Dr. Eyal.
Apologies, I'm having problem starting the video. Okay. Thank you. Sorry for that. Thank you so much, Dalia. This spring's Stahl Lecture is given by this rare and inspiring breed of an internist who is also a leading researcher on causes of great humanitarian interest and who is an important scholar in multiple disciplines. In my own area of research specialization of health resource allocation, it is hard to think of a single doctor in the world who possesses our speaker's broad and profound relevant philosophical insight. Ole Norheim is a physician and professor of medical ethics at the Department of Global Public Health and Primary Care at the University of Bergen, and the director of Bergen's Center for Ethics and Priority Setting, which has the nice acronym BICEPS. He's also adjunct professor of global health at my former Department of Global Health and Population at the Harvard Chan School of Public Health. Currently, as part of BICEPS, Norheim leads the important international research project, Disease Control Priorities Edition 4. He also leads Inclusive Public Health Interventions, a project funded by the Research Council in Norway, and he heads the Norwegian Biotech Advisory Board. In recent times, Norheim, who was born in Ethiopia, was one of the most influential native Ethiopians on the World Health Organization's thinking, though we can say with confidence, not the most influential Ethiopian in the organization. Until recently, he chaired the World Health Organization's Technical Advisory Group on health benefit packages. And among his many earlier leadership positions is that Norheim chaired the World Health Organization's consultative group on equity and universal health coverage, where I had the privilege of working under his leadership. Let me mention two other important past contributions out of many that Ole has, which don't come from WHO. One is his chairmanship of the Third Norwegian National Committee on Priority Setting in Healthcare, And Norheim also founded the International Society for Priorities in Health. Norheim's wide-ranging research interests include theories of distributive justice, inequality in health, priority setting in health systems, and how to achieve universal health coverage and the Sustainable Development Goals for health. I had the privilege of reading and teaching his work for many years. Indeed, this week I'm reading a draft chapter by my doctoral student Kyung-Do Lee, who is, I think, listening in today, who is focusing on Ole's early work with Alexander Kapelin. And for many years, it was also a pleasure for me to co-teach with Ole at the Harvard Chan School of Public Health. Ole is a mensch, a wonderful colleague, a caring clinician, and a rigorous thinker who early on pressed the need to think more about health at the level of populations, including the need to ration healthcare resources, which are always scarce, as he pointed out. As you will hear, he has also taught us of an attractive way to do so. For Norheim, health resource prioritization should always aim for the greatest number of healthy life years for all, fairly distributed. But I will let Ole elaborate about all of that. So please join me virtually in welcoming Ole Norheim.
Thank you very much, Nir, for these kind words. So I will share my screen and start with saying and thanking for the invitation to give this lecture. It's a big honor for me and nice to see you all today. And I want to start with this picture that is from Ethiopia. As Nir mentioned, I was born in Ethiopia and grew up in Ethiopia. And in 2009, I went back to work as a physician there as part of my specialization in infectious diseases and internal medicine. And I took some pictures that I will share with you today. And I've asked for permission to use these pictures. So, in my view, priority setting and ethics, even if we discuss population level bioethics, it's all about individuals. And we need to care for individuals. And as a doctor, I've always learned to put the patient in front of me first, always. So that's why this issue of priority setting and rationing is such a strong ethical dilemma for me. So I want to start with this definition of rationing or care that's maybe not so familiar to all of you, but the typical definition is that rationing is that some patients will not be offered or will be denied care that could potentially benefit them. But this happened during the pandemic, as you know, when there were not enough vaccines for everyone or not enough intensive care units, beds. So then doctors had to ration care. And this happens every day in low-income countries because there's not enough resources to treat and prevent all diseases. And it happens in high-income countries, even in a rich country like Norway, because needs exceeds what is possible to do for people, especially at the end of life. So this talk will be about rationing and about fair priority setting. And I'll start with a story from Norway. And as I said, Norway is a rich country. We have a tax-based public healthcare system, so everyone have access to all needed care without payment if you're hospitalized, with a small co-payment if you go to your primary care physician. So we basically have access to most of what modern healthcare can offer. But there are some new treatments that are extremely costly and maybe have marginal benefits that we are not including in our health budgets. And one such example example is the case of the disease spinal muscular dystrophia. This is a disabling disease that for those who are worst afflicted will take years of their life expectancy, and also means that they might be disabled. And some are bedridden, some are able to function very well in a wheelchair, and all of them function mentally well. And this picture shows a little girl called Thea, and it's from a newspaper article when the Norwegian government and the health authorities discussed whether to prioritize and cover this new drug, Spinraza, that could help patients with this disease. And the reason why it was discussed, it was at that time the most expensive disease treatment ever introduced into the Norwegian healthcare system. And health economists, they had estimated that the cost would be around $2 million per healthy life year gained. So the health benefit could be substantial, but the cost was very high. And Norway had at that time decided that there would be a threshold, and typically most treatments in the modern healthcare system cost below, let's say, 50,000 per healthy life year gained. So by introducing this very expensive drug, it could replace other and more efficient drugs. So that's why it was initially rejected, so it wouldn't be provided to Norwegian patients. But then, of course, there was an outcry in the media, and also people started to discuss, why isn't this new drug prioritized? And at that time, we had just revised our guidance for priority setting in the Norwegian healthcare system, a work that I led. And we had defined 3 criteria for priority setting. When we compare diseases and interventions, we look at health benefit, how much can we help the patient? We look at the resource use, how much would it cost, or how many doctors, or how many beds, or resources is required. And then third, how severe is this disease? It's called the health loss criterion. So the more severe disease, the more we would be willing to pay for the health gains. So then after a lot of discussion, applying the principle and also going through price negotiations with the pharmaceutical company producing this drug, the Norwegian government was able to lower the prices, and that would make the drug more cost effective. And then also with adjustment for the severity of disease, the Norwegian government in the end decided that this treatment would be offered. And of course, this little girl and her family was very pleased. But these are the kind of discussions that we have had a lot of quite recently in Norway, also with new expensive cancer drugs. So even in a rich country like Norway, we have to set priorities. My next example is a story from Ethiopia. And this is a story which is available on the Ethiopian Cancer Society website. And I've also talked to the father of this boy many times. I know him from Ethiopia. He's called Atu Wondu. And the child, Matthias Wondu, he was the third and youngest son of Mr. Wondu and Mrs. Amsala Bayen, and they live in Addis Ababa. And Matthäus, when he was 2, was diagnosed with a particular type of leukemia. And he was under intensive care at the Black Lion Hospital, the only cancer treating hospital at that time. And he underwent treatment for 26 months. But despite the efforts from his family, his physicians and nurses, Matthias lost this battle with cancer in 2003 at the tender age of 4, as it's said. And you can hear this story if you go to the Lancet NCDI Poverty Commission and look at the video by Atuwondu, Matteus's father, where he tells this story. And this story, of course, was tragic for him, but it inspired him to establish the Ethiopian Cancer Society. And they are now trying to influence the government to include more prevention and treatment of childhood cancer. And as he says in this interview, he compares survival from this form of leukemia in the United States, where more than 8 out of 10 children will survive. In Ethiopia, 10 out of 10 children, 8 out of 10 children will die, especially because of lack of access to this treatment. It's not available for everyone, and it's very expensive and almost impossible to get outside the public health system. So as Matteus' father states, there is a moral imperative to address this global inequity in Ethiopia and other low resource settings. So just imagine, think about this. In the US, more than 8 out of 10 survive childhood cancer, while in Ethiopia, 2 out of 10 survive childhood cancer. So there's a huge discrepancy in access to care and in outcomes. Is this unfair? That's the key ethical question. And I guess most of you will say, of course, it is unfair. But let me take you through some reflections around this particular case. And it's not so much about the case of this individual patients, it's also about thinking about fair allocation of resources at the population level. Ethiopia has more than 100 million people. And in 2019, Ethiopia set priorities, and they defined what they call the essential health services package. And I've selected 3 interventions for 3 conditions of chronic diseases. And they looked at the evidence on value for money. And they decided that prevention of cardiovascular disease with high risk should be given high priority, while childhood cancer, for example, leukemia, would be given medium priority. And even some of the other childhood cancers were given low priority, as they also did for prostate cancer. And this means that it will not be covered, treatment for leukemia will not be covered at the highest priority, so there will be a substantial co-payment required. And the reason for this, and this is the first ethical challenge I want to mention, is cost effectiveness. So in Ethiopia, they spend around $34 per patient per year on healthcare. It's extremely low compared to the US or Norway. So resources are limited. And for the cost of treating one child with leukemia, doctors can actually prevent many more heart attacks, or they can diagnose and treat many children with pneumonia. So if we look at cost effectiveness, there is an argument for giving other services than childhood cancer the highest priority. So if there is resource scarcity and not everyone can be treated, who should have the highest priority? That is a key question for population level bioethics. The second question is then, well, isn't childhood cancer a very severe disease? A child is deprived of the rest of their life. And that's another widespread ethical principle, actually, that many agree with this statement: everything else alike, the worse off should have extra priority. And if we agree with that, we then need to discuss, okay, who are worse off than others? And if we compare diseases or conditions, would we think that a child dying from cancer at age 4, that's worse than a father dying of heart attack at age 60? So these are the ethical challenges we need to discuss. I have concluded that I believe that dying as a child is worse than dying as an adult, but people strongly disagree on this. So this is a continuous ethical debate around who are the worse off in terms of lifetime health. And resolving that question is important for setting priorities. The third ethical challenge here is, what view do you have on global justice? So if you adopt a cosmopolitan perspective, you might argue that everyone's interests should be valued equally, regardless of where you are born. And if you subscribe to this view, you might think that if childhood leukemia is curable in the US, it should also be curable in Ethiopia. But then you have other arguments, and one position is called statism, the view that state borders have ethical significance and that citizens' interests have priority above non-citizen interests. And we saw a lot of this during the allocation of COVID vaccines. Your government, my government argued that our citizens should have priority before people from low-income countries such as Ethiopia. And if you're a realist, you have to realize that there is no global government. So how can it be global justice? Again, this is an issue discussed a lot in ethics, in global justice, and depending on where you land on this question, you might judge the case of childhood cancer and Matteus's fate differently. So I would summarize it just to outline three perspectives here. Global unfairness. Obviously, if you agree with the cosmopolitan, at least when it comes to health, you will argue that unequal access and unequal outcomes for children with leukemia, regardless of where you're from, that is plainly unjust and unfair. But if you realize that that global justice is infeasible, you might move to a second position and be interested in within country unfairness. So within a country like Ethiopia with limited resources, we could say that there is unfairness if there's unequal access to healthcare for the same condition in the same country. If someone who are very well off with a high income can travel abroad and get treatment for cancer or buy that service in the private sector, then there is unfairness. The third unfairness, and that's what I worked mostly on, is unfairness in priority setting. And that's a complicated issue because it would say that if we could define high priority services, it would be unfair if there's unequal access to healthcare for these high priority services. But we might accept that there is unfair access to low priority services. So for instance, children dying from pneumonia, it can be treated very well at a very low cost. So in my view, it's totally unfair that anyone dies from pneumonia in Ethiopia, and it's the biggest killer in Ethiopia. But a heart transplant would not be possible to give high priority in the Ethiopian system. So there we might accept that there is unequal access to such a low priority service. So this brings me to the fourth ethical challenge, how to define high priority services. And this is a health policy issue. Everyone concerned about sustainable development and universal health coverage have discussed this issue. How should we define the really high priority services for which everyone should have equal access without payment, without financial risk? And in my view, the resources for answering and discussing this question comes from population level bioethics. And this is a rather new field of research and ethics. I would say named by Dan Wickler and Dan Brock in a paper and a book chapter from 2009. drawing, of course, much older traditions of theories of distributive justice and fair priority setting. And to answer this question of who should have high priority, it's helpful, in my view, to draw on these theories of distributive justice, looking at population health from an impartial perspective. A lot of people are fighting for resources for their disease. So we could easily say that, of course, childhood cancer should have top priority. But then what about everyone dying from diarrhea or pneumonia or cardiovascular disease, suffering from mental health disorders? There are so many competing needs. So by imposing an impartial perspective, population level bioethics can help clarify these issues. And this strand of bioethics is also very much informed and should be informed by facts, by epidemiology, public health, evidence on what kind of intervention works and don't work, demography, and economics. We need to take into account the cost of health services. And what is interesting, and the big advantage with population level bioethics, is that it brings this population perspective. We look at the distribution and level of health over the lifetime, and we can also bring in well-being into that picture. And it takes as a point of departure that all people have a legitimate interest in living long and healthy lives. And the issue then is to discuss how to achieve this goal, that everyone could have the best possible life, but that health and life is also distributed fairly when we know there is scarcity of resources. Another source that I've found very useful is this ethical theory called Prioritarianism. It's an ethical theory that gives extra weight to the well-being of the worse off. And it also gives weight to improvement in health when this theory is applied to healthcare. And in general, in ethics, there was a Rutgers philosopher, Larry Temkin, that you might know, who first articulated this position, and it became famous after the Oxford philosopher developed it further. And what I think is so promising with this ethical theory that Derek Parfit developed is that it combines both this concern for efficiency to really improve well-being, but also take into account the worse off and fair distribution. And it's also so interesting because it can be informed and it can inform quantitative analysis and economic analysis. And I've contributed to a book that's shown here called Distributional Cost Effectiveness Analysis. And this is motivated by my view that for ethicists to really have an impact on health policy and on making a difference in the world, you can have more impact if you can also argue with numbers, not only with words. So merging good ethical arguments with good analysis can help decision makers make better decisions. So my belief is that systematic priority setting based on ethical theory and shared ethical values can reduce the amount of unfair rationing. If we can help governments and doctors make better decisions informed by evidence and ethical values. And of course, we disagree a lot about values and basic ethical principles, but I think it's hard to disagree with these two, to improve health and to distribute health as fairly as possible. And even if prioritarianism has a lot of shortcomings, it's one interesting theory that can help us clarify the issue of priority setting. At the policy level, the World Health Organization is giving advice to countries on how to set priorities. And as Nir Eyal mentioned, WHO, the World Health Organization, asked a group of ethicists and some economists and the human rights lawyers to recommend criteria for priority setting. How should we decide which services should have the highest priority? And after a lot of discussion with people from different ethical perspectives, we actually agreed on some mid-level principles or criteria. We agreed that it's relevant to look at the cost effectiveness of an intervention. If you can save a life for a low price or a low cost compared to another intervention that would cost 1,000 times more to save one life, that is ethically relevant. And that is the dominant approach to priority setting in many countries, only looking at cost effectiveness. So we added the second criterion: we should give extra priority to the worse off. And the worse off can be defined as the one who is worse off in terms of health, like children with leukemia, or those who are worse off in terms of income, the very poor or people with other disadvantages. So it's relevant and important to take equity and fair distribution into account. And third, we argue that financial risk protection in a system where people pay out of pocket if they can't get access to publicly available services, people can be pushed into poverty when they try to access services. So that would also be relevant for defining high priority services. And based on these criteria, the World Health Organization then recommended that government could divide classes of services into high, medium, and low priority, and that they should scale up as quickly as possible and get better financing of high priority services, and then scaling up, offering more and more medium and later low priority services, so that everyone could have universal access to high quality services that they need without financial risk. In my group, we are also working, therefore, on producing and generating evidence on cost effectiveness, who are the worse off, and financial risk protection. And as Nir mentioned, I've been asked to lead this work that started already in 1993 with a World Bank report, Investing in Health, led by Dean Jameson. And this initiative have produced very useful evidence in 3 editions. The latest edition was published in 2018 in 9 volumes, giving recommendations on high priority services in childhood diseases, in maternal health, in mental health, in cancer, in chronic diseases. And this has become a rich source of evidence and recommendations for countries dealing with this ethical challenge of fair priority setting. And I'm now leading and planning the work for DCP 4th edition. And by the end of this year, we hope to produce the first volume that will report on experiences with setting priorities in several low-income countries, including Ethiopia, Pakistan, Afghanistan, Sudan, a lot of countries where we have worked with governments and local researchers to develop recommendations. In volume 2, we will discuss and evaluate global threats to health, including the pandemic, and critically summarize experiences and what we know about pandemic preparedness and response. In volume 3, we will look at intersectoral prevention. So we're not only interested in what the healthcare system can do to reduce health and prevent disease, but intersectoral policies like better traffic regulation, tobacco control, climate change, reducing actions, and so on are also very important to protect life and health. And finally, in volume 4, we will revisit the recommendations for high priority services for universal health coverage. Let me end this little talk then by returning to the question about should childhood cancers be prioritized in Ethiopia? And obviously you can, I think you have guessed that I have strongly concluded already. I think it's globally unjust that children die of curable diseases in a country like Ethiopia. But if we look into the situation in Ethiopia, they don't get more resources, even if I think it's unjust that they have so little resources for health. So I have a PhD student here in Bergen, an Ethiopian PhD student, who's exploring this question. And he's actually doing his PhD on collecting all the cost and estimating the benefits and the effects of treating childhood cancer in Ethiopia, because there have never been such a study in this country before. And he will also explore how much weight to assign to the worse off, and to what extent will prioritizing these services provide financial risk protection. So if you're interested in the answer to this question, you can follow us on Twitter or on Facebook, and we will update you when Mizan has completed his PhD work. And we hope that this will be relevant also for the Ethiopian government when they are revising their priorities. So let me end with this quote from Amartya Sen in his work, The Idea of Justice. He argued that we can disagree about what perfect justice means, but we agree and we know enough to identify injustice, and we know enough to do something about it. And that's what motivates me in my work as an ethicist. Thank you so much.
Wonderful. Thank you so much, Ole, for moving and very thought-provoking talk. I will moderate the Q&A, which is based on the questions in the Q&A, and please continue to place questions there if you would like us to raise them, as well as questions that people put in during the registration. Let me start with a direct just challenge for clarification of the last point. Haven't you actually given us already your answer, which is a provocative answer? Am I right that there is no way that the numbers could work out that childhood leukemia would be more cost effective to treat than childhood pneumonia in Ethiopia? In both cases, it's a child, it's life risking, so maybe the competing parties are equally worse off. That won't break the tie, or sorry, make a difference. And therefore, maybe your position is the very difficult to swallow one, that this child should not have gotten the care that they needed in their struggle against cancer in Ethiopia, from the point of view, of course, of the Ethiopian health decision maker that looks with dismay at the fundamental injustice of global resource allocation.
Yeah, so my view here is that if we look at treatment for pneumonia and treatment for childhood cancer, and we want to apply both a concern for improving health as much as possible and also giving extra priority to the worse off, treatment for pneumonia would, in my view, then have higher priority than childhood cancer. But it could still be given priority if it's within the resource constraints. So the interesting challenge I see is comparing childhood cancer with some of the more cost-effective treatments for cancer for adults, for instance, or cardiovascular disease for adults. So then if you assign extra priority to the child because he or she is worse off, you could reverse that ranking. But people disagree about that. And many wise people have argued that we need to take into account the well-being and the productivity of adults, for instance. So it's not a straightforward answer to this question. But my view, after some reflection, is that I would give extra priority to those who die young.
Thank you. People relatedly to what you just mentioned asked how we should think about prevention versus treatment and cure.
Yeah, I think that's a very important question, and we can evaluate all these policies in the same way. So if prevention is more cost effective and prevent disease, severe disease, it would come very high up on my priority list. But even if you prevent a lot of disease, what do you do with those who are unlucky and end up with the disease, with the cancer? So then you have the dilemma, and in practice, we see that doctors and governments always provide some services for those who are falling ill. So it's not easy always to prioritize prevention. So in practice, we have to build a system where we both have public health and policies that prevent disease, but also have set up a system with primary care and with sometimes specialized care that can treat people who are ill. And what my view is that we could do more to prioritize prevention above treatment. And one way to do that is to provide better evidence showing the huge benefit you could gain from more prevention.
Thank you. I'm going to quote another question. How do you see this important work interfacing with the growing literature about syndemics? How should we think about individuals or populations dealing with multiple comorbidities and not just a specific disease?
Yeah,
are they the worse off, or how does that work?
That's a very good question, and we have actually been criticized in DCP, in the Disease Control Priorities Project, and challenged that we have this very disease orientation of our work. And there are good arguments for thinking about people, and people don't only have one disease, they might have many conditions. Sometimes they don't even have a name for their condition. So thinking about other ways to classify people and services. And what we and many others have proposed, and that we will probably do, is to look more at platforms. So looking more at primary care, what kind of services should be prioritized at primary care, and community health services, and not caring so much about particular diseases, but thinking about how can we serve people who contact the doctor or the health center with some complaints, and then developing priority systems that are more based on the delivery platform of services. Others who are more concerned about people living with disabilities and so on, they don't like this narrow focus on diseases. But in practice, in my view, it's very useful to have diagnosis and talk about interventions, because we know that they have very different outcomes. But this is a debate that is alive, how to classify people, how to classify interventions, and how to set priorities. And this is an open debate that I would invite more scrutiny for.
So I'll pursue this one and grill you or scrutinize or whatever. Why is it impossible to prioritize per individual and not per either disease or intervention or point of delivery?
So some people think that the narrow disease orientation is too narrow. So we miss the determinants of disease. We miss the context, the lives, the circumstances they are living under. So we should be much more concerned about the determinants of health and the circumstances people are living under, and that the best way to really capture the concerns for those who are worse off is not looking at the diagnosis, but more describing the condition they are in. So I think that would be the main argument.
Good. Changing gears to a different question. What do you think? How should healthcare systems think about prioritization of outcomes which are not strictly speaking health outcomes? The question the example given, I don't know if you would agree that this is an example of that, is palliative care, in as much as what it gives us is better well-being, maybe a better death, which might not count as better health.
Yeah, that's also a very good question. And I think that's both for kind of the economic models that we use, and even this applied prioritarian framework has a limit for these kind of services. I would mention palliative care as one type of health service that is important for other reasons than that it will prolong your life, obviously. So it cannot be measured in terms of traditional health outcomes. Another example would be abortions. We can disagree whether it should be legal or not. And for those who think it should be legal, how should we count the benefits of such an intervention? That's also really tricky. So at the borders of health and life, at the end of life, at the beginning of life, there are a lot of these unresolved ethical issues. How to measure health outcomes and how to assign value to some services that cannot be captured by the standard measures.
Thank you. Someone asked, we know inequality of healthcare exists, but what can we as patients do about it? When we are already sick, we sometimes don't have the ability to fight the injustice if we are denied resources that we should be given. And I might add, and if we do have the ability to get what you've argued is privilege for us, that maybe others should have gotten at a higher priority than us. Is it okay for patients to use sharp elbows and get the best healthcare that they need, or do patients also have responsibility to ration the care that they need?
Yeah, that's a complex question. I really understand every individual who fight for access to care and who really see that as a right. But I think what we can do, at least as citizens, is that we can argue for a universal healthcare system. I'm also Norwegian, even if I grew up in Ethiopia, and in the Scandinavian countries, we have a publicly funded healthcare system, and I know how well it works. So everyone have access to services when they need it. It's very simple. It's financed over the tax system, and it's very rational. It's much more efficient to have a kind of public health insurance system that is mandatory for everyone, because it redistributes from the wealthy to the poor, from the healthy to the sick, and from the young to the old. So it protects everyone if they become sick, and it has this redistributive features that, in my view, would be rational for everyone to wish for. So I think what we can do is to argue for universal health coverage, whether it's in the US or in low-income countries. And that's part of the Sustainable Development Goal for Health, the target 3.8 that all countries have signed up to, actually, to achieve universal health coverage.
Thank you. I'm sure you would have many supporters on this position in our audience. How do we reconcile the preferences of the population or stakeholders and the prioritizations recommended by experts like yourself, who may have given this years of thought? For example, what are we going to do if voters may prefer cancer treatment over pneumonia, even if you think that pneumonia should have gotten prioritization in a certain resource board setting?
Yeah, thank you for that question. And it brings up the need to think about fair process and democracy. So what I didn't talk about in this talk, but which is important for me, and it's also a recommendation from the World Health Organization and many others, is that we also need public input and deliberation about priorities. And as I mentioned, we disagree actually on a lot of these ethical dilemmas that we encounter when we discuss priorities. And our role, my role as an expert, is also to facilitate deliberations. In the end, I don't believe government should listen to me as an expert. I can give advice and frame, create a setting, provide evidence for decision makers, but the decision makers should make sure that there is public participation and an open debate about priorities. And I would, as a Democrat, accept that if we had a fair process deciding on priorities and the public really rather would like to prioritize cancer treatment above pneumonia, we'll have to accept that, even if from my expert perspective, it wouldn't be the best thing.
So in the spirit of grilling, well, it became pretty clear that the public voted the way it did out of, it's not just disagreement with your ethics, some profound disagreement, but something like either misunderstanding of the facts, flagrant racism for a disease that, say, may prevail in one racial group more than in others. Would you always go with the public preferences after you've tried to inform the public some?
No, I would not. So there are limits, and we know there are no perfect democratic procedures. And there is an inherent challenge in kind of setting priorities through democratic mechanisms. For instance, there are a lot of so-called orphan diseases, very rare diseases, like muscular dystrophy that I mentioned is very rare, just a few patients in Norway. They would never get a social movement for that condition. So we might be at risk if it was kind of a vote. You would get cancer and cardiovascular disease getting the higher votes because it's so common. So I think we need a system, we need ethicists, we need politicians, we need a system of rules that can create a fair system so that everyone's interest is taken into account as well.
Speaking of racism, brings out a natural question these days. What concerns do you have with potential racial and gender biases that may be introduced into epidemiological and economic population data that may impact on cost effectiveness and population level ethical decision making and the related assessments? Consider recent critiques of algorithms, AI, big data, and the biases that they already contain. How do we deal with those when we're trying to be fair?
Yeah, I think that's it's a profound question, and we have learned so much recently about these biases, because what I recommend and what government follow is very much this idea of building on evidence and medical research. And we know that this research is biased. So a lot of groups are underrepresented, and there might be racism and or blindness biases in the way we collect data and do studies. One example would be that cardiovascular disease is very well researched. So we have very good evidence, but for a lot of mental illnesses, we have less research. So there will be a bias in the amount of evidence that we have. So what I've always recommended is that decision makers would not only look at the evidence and reproduce the biases in research, but will also need to make judgments about and correcting for these biases. And that's an additional argument for also having more public involvement and more public discussion around priority setting. It cannot only be expert and evidence driven.
Thank you. You've touched on this, but maybe worth getting into more nitty-gritty. The WHO Director General, the other Ethiopian and the organization, suggests that broad administration of the booster doses is unjust, unfair, and immoral. Is it ethical to vaccinate and boost the low risk in high-income countries before the vulnerable in low-income countries?
Yeah, I worked a lot on this issue recently, and in my view, even if we don't have a perfect, or we have far from a perfect just world, I think it's an ethical obligation to make sure that health workers and the most vulnerable in countries who haven't been vaccinated at all should be protected before we, who have been protected by 3 doses, for instance, or 2 doses, and have a minimal risk, that we reallocate the resources. But I have to say that the global allocation of vaccines that we have experienced the last year or so has been very disappointing. I had expected that when the globe confronts a pandemic and we are all in the same boat, we would show more solidarity. But the opposite happened. We hoarded vaccines, and all the health ministers of the world argued and hoarded vaccines for their own countries. So vaccine nationalism was the rule, and there is nothing left of this idea of that we are equal citizens regardless of where we are born or live.
So going back to the individual patient question, would you say that individuals in high-income countries should refuse booster doses because fundamentally these doses should have been first vaccinations in sub-Saharan Africa, for example?
I think that's a hard question. No, you have to be realistic. This is more of a systems failure. It wouldn't help if an individual refuses a dose. So we need to work at the systems level and improve the system. So I will not recommend heroic sacrifices that don't really help enough. We need to think about the effect of what we are doing as well. So I think we will have more impact if we could improve the system and prepare for the next catastrophe.
So a really good lesson in the importance of exploring issues, not just at the individual level of the individual patient, the individual provider, caring for an individual patient, but rather we must think of issues, as you do, from a population level perspective when it comes to health policy, social determinants of health, and other topics that people asked about that we didn't have time to ask you about. Yeah, and
we must engage decision makers at the global level, in the UN systems, but also the pharmaceutical industry, politicians, and there is a lot of interest now to try to draw lessons learned from the pandemic and thinking about how we can improve and prepare, having new agreements on how to handle the next pandemic.
Thank you so much, Ole, for a truly profound and fascinating talk. And thanks again to the Stahl family and to all of you for joining us today. Have a good week.